Good evening, friends. This is the third edition of Algorithms in Urooncology, and the theme focuses on newer topics, and we try to get in evidence and try to assimilate and process them and present them to our viewers with a view that they can form a mental algorithm in their mind, which will help them to deal with patients in their day-to-day practice. Today, we are going to talk about prostate cancer genomics and genetics, and we have got eminent faculty with us, which I'll be introducing during the course of the webinar. Before we go to the chunk of the discussion, let us talk about the present scenario of prostate cancer in India and a few about genetic involved in it. As we know that prostate cancer, 14% of it are new cases which have been found in 2020. In India, the incidence of localized prostate cancer is increasing because of the use of PSA in executive health checkups, which are more rampant, especially after the COVID infection. At the same time, we also find considerable amount of metastatic cases. There are newer technologies coming up in the form of robotic surgery, as well as there are enhanced ADT and newer drugs are available in India to add to our treatment armamentarium to treat these patients. If you look at the dynamic clinical landscape, you'll find that most of these drugs like abiraterone and enzalutamide are used in CRPC, but they have also moved in the domain of metastatic hormone-sensitive prostate cancer. And we have these drugs like olaparib and rucaparib, which have come into the forte. And if you see that for the monotherapy, what is been considered is the genetic analysis. Talking about genetic analysis, let's talk about genetics and prostate cancer. As we know, prostate cancer progresses from a normal epithelium right up to the metastasis, and each step has got its own share of gene inactivation, gene overexpression. There are some tumor suppression gene, tumor promoting gene, which add to the forte. Moving on, very basic, we know that a DNA translates into RNA, and that translates into protein, which is expressed. And what we look in prostate cancer, this is expressed in the form of serum PSA, expressed in the form of the Gleason score and the Gleason grade. We have got markers which look at each and every subtype as well, like Prolaris looks into the protein, the Oncotype DX looks into the RNA part of it. We have this group of tests, and we'll be focusing on these two. One is the molecular biomarkers, which will be addressed by Dr. Dipen Parekh, and the genetic analysis, which will be addressed by Dr. Sanoj Punan. Moving ahead, what are mutations? Now, mutations of two types. Somatic mutations are acquired subjective to changes due to treatment, and they're found in tumor tissue, whereas germline mutations are hereditary, present in all cells, normal and tumor cells as well. If you have a quick deja vu, this is a gene with two alleles, and when one of the alleles has a mutation, it is called a monoallelic mutation. And when both the alleles undergo mutation, because of tumor pressure or because of environmental pressure, it's called biallelic mutation. This is a concept which has come up, and hence I felt to mention it. Genetics, as we all know, is a study of inherited traits and genes, and genomics is the study of how a set of genes behave. Germline test is to examine mutation inherited from either parents that are present in each cell, either normal or tumor. And genomic test examines somatic mutation in tumor itself, either in the form of molecular test or assays. Now, if you look at the pathway of this DNA repair, or where the mutation occurs, there are 5 predominant pathways. But the most predominant is the DNA repair pathway, in which we have either the HRR, the homologous recombinant repair genes, or the MSI mutations. And these are important because either the HRA mutation have got implications of predicting whether you can have prostate cancer, or they have therapeutic implications, which we'll be listening to from our experts. Looking at genetics in inherited prostate cancer, familial prostate cancer, about 20% of cases, out of which 5% are purely inherited, and rest are probably because there is a mutated single allele which has undergone a transformation and become biallelic, and it is expressed itself as a cancer gene, a cancer cell. If you look at this patient has born with a mutation in one of the allele, and because of the tumor-driven event in his life, this monoallelic mutation becomes biallelic, and it gets expressed in the form of a tumor cell. These are the gene used in screening panel, and why it is important, because if you take one gene of them, BRCA, it increases the prostate cancer risk by 8.6 fold. Looking at genetic aspect in acquired or sporadic prostate cancer and looking at the subtype like localized or metastatic prostate cancer, here is a normal individual with normal allele, normal genes, and during his course of lifetime, he has a spontaneous somatic mutation in one of the alleles, and later on, this monoallele mutation becomes a biallelic loss and it becomes transformed into a cancer cell. These are the genes which are used in metastatic prostate cancer. Now, this is the same slide which I showed you before, and I'm trying to emphasize here that PARP inhibitors have got therapeutic implications, which we are going to hear about later. Now, before we planned this webinar, we had a local survey done. We spoke to some of our friends, and they had some questions which I'm going to put it up for our esteemed guests and our speakers. One is, how effective are these biomarkers as genetic tests? Can they help us to suggest active surveillance? What are the indications and what panel do we suggest? And do they really change the clinical outcomes? As far as Indian perspective is concerned, whenever there is a new drug or a new testing modality introduced in our part of the world, these are the four parameters under which we gauge it. One is the availability, the applicability, the affordability, and the acceptability of that particular drug or test. With this, I end my talk and we move on to our first talk, which is focused on molecular biomarkers. And it's my great pleasure to introduce our first speaker, Dr. Dipen Parekh, who is a professor and chair of the Department of Urology, Director of Robotic Surgery, the Victor A. Politano Endowed Chair in Urology, Chief Clinical Officer in the University of Miami Health System.
First of all, let me just say that this is one of the best introductions to a talk that I've seen in a long time. I always enjoy participating in forums where I actually learn more than I can share. And I already feel after Santoshi's talk, I've learned a little bit more than I can share with you. But thank you, Santosh and Vivek, for the kind invitation. I think this is a wonderful format that you have made, this whole algorithms. I think it's very precise, very scientific, evidence based, and I think it's terrific. I wish I had mentors like you and Vivek when I was in India as a resident or a fellow with these type of activities. So thank you. So today I'm going to speak on the genetics and markers, and I just want to say that we're also very lucky to have one of our faculty from University of Miami, Sanoj Poonen, as a part of his talk. Sanoj is a shining star in the field of prostate cancer. He has done some phenomenal work, and you'll see that a lot of my talk will focus on the great things that he has done within our program and within our health system. And he's one of the leaders in the field of localized prostate cancer, active surveillance for prostate cancer, as well as prostate cancer detection, biomarkers. Is nationally, internationally renowned. So we're all very fortunate to have Sanoj as a part of of our faculty. So I'm going to talk on genetics and markers for prostate cancer. So I'm going to start off with an example, and the example is you have a 67-year-old male with a PSA of 5.7, relatively healthy individual, has good sexual function at baseline, and has a Gleason grade 1 prostate cancer on one side, and a small focus of Gleason grade 2, which is 3 plus 4, 7 prostate cancer on the other side. And so, what do we do with them? So, if you look at the NCCN guidelines for prostate cancer, well, the guidelines show that for those patients with a life expectancy of equal or more than 10 years and with this type of disease, you can definitely consider doing some genetic testing or molecular based assays like the Decipher. As Santosh pointed out, we have three main tests available in the United States, the Decipher, the Oncotype DX, and the Prolaris. They're three completely different companies. They look at all three of them look at several different genetic pathways and markers that Santosh highlighted in the in his presentation with very little overlap. So you can actually, in your mind, think about the three tests that are looking at three different genetic uh, combinations, if you will, to give you the same answer that you want. Now, now these are the three tests, as as I mentioned. The one on the left is the Oncotype DX, the GPS score. It's very popular in the breast cancer setting, but it has been around for quite a while now in the prostate cancer setting. It is used mainly in the diagnostic and prediction or prognostic space for patients on active surveillance, as well as post prostatectomy. Same with the Myriad Polaris, whereas Decipher made its mark uh, predominantly initially at least in the prognostic space after you do a prostatectomy and submit the prostate tissue for the decipher testing, and then that would tell you the prognosis or the risk, and that would drive what do you do next in terms of adjuvant, salvage, whatever treatment that you want to consider. Now, if you look at the genomic landscape of low risk prostate cancer, this is where I'm sorry. If this is where you see, there's a very nice paper from Matt Cooperberg from UCSF published recently that typically, if you look at the clinically low risk prostate cancer, so these are the patients that, for the most part, if they show up in our clinic, we are going to offer them active surveillance. But when you look at these patients and when you do genomic studies on these patients with low risk prostate cancer, if you focus on the right two bars, about 20% of these patients with low risk prostate cancer have actually a high risk genomic scores. So that just shows the heterogeneity that you'd assume that basically low risk prostate cancer, you're going to treat in a certain way. And suddenly, let's imagine if you do a genomic test on every single patient who comes to your clinic with low risk prostate cancer, you're going to find 20%, one out of every five of these patients with a higher genomic score. That means there's a conflict now. The conflict is that your established clinical guidelines and pathologic guidelines tell you to watch this patient. Now you have this study, a genomic study that tells you that no, they have a higher genomic score that predicts poorer prognosis. So what do you do? But that's the biggest question in the whole field of genetic testing. How actionable are these tests? What do you do with the results of these tests? If always very easy when the results of the test, the genomic test that you order, they confirm to your clinical criteria and they confirm to your own bias about what you want to do with the patients. It's always a challenge when the genomic test results are contrary to your established clinical criteria and contrary to what you are proposing to the patients. And then when that happens, at least in my practice, I tend to go with the clinical factors rather than the genomic factors as such. But perhaps the ideal answer is it should not be used just by itself. It should be used like most things in prostate cancer in combination with all the other information that is available for that particular patient. Now, if you look at the adoption of, and I know that Vivek is going to touch upon this in terms of the status of genomic testing in India, but if you look at the status of genomic testing in the United States, it's very clear that it's all over the place. It's very variable. There are certain groups or certain geographic locations that have a higher incidence of genomic testing compared to those who don't. And when you dig deeper, you find that most of this is related to the socioeconomic status of the patients rather than anything else. So the point I'm trying to make to the audience is that even in a country like United States, where these tests have been now in existence for almost a decade or perhaps even more, it's not as universally used as you think it is. Now, so the question is, should we even be using tissue-based genomic prognostic tests? What is the evidence if the answer is yes? What are the limitations of these tests? One of the main limitations that we'll discuss in great detail is the tumor heterogeneity. And then at the end, what test, if any, should we be ordering of the three tests that I just mentioned? So let's begin to answer each of these questions. So should we be even using tissue-based genomic prognostic tests? Now, we have a very robust evidence in breast cancer. If you look at this table, most of the studies on the breast cancer realm, I want you to focus on the category of evidence and consensus. Most of these studies are level one evidence or at the worst level 2A, which means that most of these studies are prospective studies, well-conducted studies with good sample size that are designed to answer relevant question. We are talking about breast cancer. Unfortunately, we don't have that in prostate cancer. In fact, breast cancer is so much ahead that some of these genomic testings are used as a criteria for driving randomized clinical trials. So this is an example where a gene expression assay was used as a criteria to offer or not offer adjuvant chemotherapy in patients with breast cancer. So they are at a completely different level of advancement in terms of knowledge in their field that allows them or enables them to use these tests more meaningfully than we do. Now, if you look at the NCCN guidelines again, most of these studies that highlight the efficiencies or the use of these study of the genomic testing, they're all retrospective studies, and therein lies the problem. We simply don't have high level of data or evidence to strongly support any of these testings. Now, this is a very good study that came out from the PASS cohort, which is a active surveillance cohort. And what they did was they did in more than 400 patients, they did a GPS score in all their prostate biopsies, and they wanted to ask two questions. One question was that do these GPS score can they predict upgrade of the biopsies in those patients who progress on active surveillance? And then the second question was for those patients, a fraction of these patients who underwent radical prostatectomy, do the GPS score, does it basically predict for adverse pathology? And what they found was that for biopsy upgrade, which is the most actionable item for patients on active surveillance, both for the patients as well as for the treating doctors, is that for that, it totally did not predict. So a GPS score did not predict upgrading on the biopsy for patients with active surveillance, which in effect tells you that it's kind of useless in terms of patients on active surveillance to help either the patient or you in predicting that this patient will either progress or not progress on active surveillance. And even when you look at the pathology result for or adverse pathology on those patients who underwent radical prostatectomy, even though the GPS score did predict for adverse pathology in one model, but the moment you add other variables in the model, like PSA density, that significance of the GPS score disappeared. So, to put it in simple English, for patients on active surveillance, either in terms of biopsy upgrade or in terms of predicting adverse pathology for those patients who undergo surgery, the genomic testing, at least with the GPS score, it did not help much. This is a very exciting study that is being conducted right now in the state of Michigan in terms of genomics to adjust outcomes in prostate cancer, but it is still very far away. I don't think so we'll get the answers to these questions for another 5 to 10 years. So we'll have to wait. But I applaud Todd Morgan and other folks in Michigan to conduct this study, and we'll see what it shows. So now let's talk about the tumor heterogeneity, which is an innate problem for prostate cancer. This is a very nice paper again. This came from Michigan. This looked at four patients or four with tumors, four different tumors, gross tumors, and what this study shows that when you conduct the same test on different tumors, or even more importantly, when you conduct the three different types of the genetic testing on the exact same tumor, you come with completely different outcomes. So here, as you can see, for example, on the left side, CAP001, so this is patient number one, and you'd assume that if this patient truly has a genomic instability or is more prone to a poorer prognosis, you should have the same answer from different genomic testings, even though they test different pathways, but that is not the case. It is all over the place. And then, even within the gross tumors, when you take different elements of the tumors and subject the same testing, you find a different answer in all of them. So basically, what it shows is that the prostate cancer that we see clinically is extremely heterogeneous, and just a one score, one genomic score from one location will not predict the overall situation of aggressiveness or lack thereof in a prostate cancer patient. This is also a very nice study from Ganesh Palapattu from Michigan. Now, again, if you see on the left side, one of the main the main um, advocacy for genomic testing is that if you are sampling a low grade prostate cancer in the left side, it doesn't matter that the genomic testing itself should be able to predict the overall landscape or the overall situation, the aggressiveness in the entire prostate. So that means if you see this tumor on the left side here, and if you biopsy this sample, or actually rather, if you take this, so this is a patient with you have a Gleason grade 1 prostate cancer, but along with this, you also have a high grade prostate cancer. Well, people who propose genomic testing, they say that if you biopsy this, this should show genomic instability. That should tell you that this particular patient does have more of a genomic stability that can then tell you or guide you that this patient does not, even though on the Gleason side it's a low grade, but because of the genetic testing, this patient actually has high grade prostate cancer. But that is unfortunately not the case. That what we found was in this, as Ganesh showed in this paper, is that there is a tremendous amount of heterogeneity that basically the genomic features of this tumor, the low grade tumor, it's going to be different from the genomic features of the tumor in the blue. So that means ultimately what it means is that what you're going to find in the genetic testing is purely based on what you're hitting. It's purely based on sampling. If you are hitting the right sample, and even within the sample, the right, the most accurate part of within that sample, you're going to get a better answer. So it becomes more a function of sampling rather than a function of true genomic landscape in that particular patient. This is a study that Sanoj is leading, the Miami Mass trial for active surveillance. This is one of the landmark studies that basically follows these patients longitudinally, patients on active surveillance with low risk prostate cancer, with the combination of MRI and biopsies, and all these biopsy scores are longitudinally submitted for pathologic analysis as well as for genomic studies. And this is where this is a study that was done by us in the University of Miami, and where it showed that, as you can imagine, that when you did genomic studies in all these patients on active surveillance, that they correlated with two features. One is the grade, and one is the MRI findings. That means higher the grade, the Gleason score, more aggressive the Gleason score, more are the chances of finding the genomic risk in the genomic testing. And the same thing with the PIRAT score. Higher the PIRAT score, higher the chances of finding a high risk genomic testing, which is very intuitive and it makes sense. The high PIRAT score translates into high Gleason grade, which translates into higher chances of genomic testing being positive. But the question is, we knew that there's going to be variability in the genomic risk assessment based on the previous studies that I showed, but we just wanted to find out what's the magnitude of the variability. And basically, we wanted to see how much did the genomic risk change depending upon what test we use and depending upon the core that was sent. So here we can see that basically in about up to 20% of patients, there was a difference in the genetic risk score based upon the test used and based upon the code that was sent. And then you further see, look at the two features that I mentioned, the grade and the Gleason score. Again, in about 75 to 87% of the patients, the core with the highest grade at the highest genomic risk, which is fine, that's what you'd expect. But this is where you want to ask the question, is 75 to 87% a good enough bar for us to accept? Because that means that potentially in about one fourth of the cases, you can actually take submit the genomic testing from the highest Gleason score core, and yet you'll find a different answer. So even within the two main factors that intuitively make sense that will predict the genomic testing results, there is a almost 15 to 25% discordance between the highest grade, and the risk score on the genomic testing. And the same thing happened in MRI as well. That in about 72 to 84% of the cases, higher pilot score on the MRI found the highest genomic risk, but in the remaining, it did not correlate. And this is a classic example of a patient on the MASS trial where the patient progressed from 2 cores of Gleason 6. On a confirmatory biopsy, it went to 9 cores, and we submitted each and every of these 9 cores to all the three testing, which is the Decipher testing, the Prolaris testing, and the GPS score. And you can see here the results, it's all over the place. It's almost impossible to interpret in this particular patient based upon just the genomic testing. So the question is, what test should I get today for genomic analysis? And the answer is, I don't know for sure, but my suspicion is I don't think so anyone else knows the answer at this point in time based upon the data. People can have biases and people can have point of views, but I don't think so I've seen any facts or evidence that support the use of any one test or the other. So this is an example of the type of work that is being done in the breast cancer side, where for a lot of these studies, they actually do a head-to-head comparison between all these tests on the same population. And that's the type of rigor on a prospective basis. And that's the type of rigor that has not been done in urologic studies for prostate cancer until we really do high-level prospective studies comparing a lot of these tests head-to-head, and knowing that these tests can be very expensive. I don't think that we are going to find any robust evidence of utilizing these tests. So my simple answer is, at this point in time, I personally don't use these tests unless the patients are driving me to use this test. And even when you use this test, when it validates what you already know and what you're already thinking, these tests look good. And when it contradicts what you feel you know and what your bias is in terms of treating the patients, that's when the difficulty arises. In my case, between the established clinical criteria and imaging and the Gleason grade and the genomic testing, if I had to choose one, I would still choose the established criteria. And I would never ever make a decision contrary to what I was going to make solely based on genomic testing. So again, with this, I'll stop. And again, I want to thank both Santosh and Vivek.
My great pleasure now to introduce Dr. Poonen. So Dr. Santosh Poonen is an associate professor of urology at the Department of Urology in Miami. Poonen will be talking to us today on metastatic prostate cancer and the genetic testing that is involved in those cases. Thank you.
Thank you, Vivek. Everyone can see my slides okay?
Yes, sir.
Great.
Yeah, we can.
Great. So good evening, everybody. So I would like to thank Santosh and Vivek for the great introduction and moderating this conference. And I'd like to thank Dr. Parekh for his earlier comments. And I echo his latter comments about Vivek as a fellow. He was a very bright guy, excellent surgeon. And I really enjoyed having him in the OR with us on Fridays. We were always trying to reinvent ways of making challenging surgeries better. So I definitely miss those times. So for that, it's a very honor and a pleasure to be here. And I was asked to speak about genetic testing in metastatic prostate cancer. And I'm going to cover the who, the how, the what, and the why. Now, these are my disclosures. As you can see, I work with a lot of different biomarker companies, but I think the biggest disclosure I want to let you know about is that I am not a genetic person. So by no means is this going to be a comprehensive talk about genetic associations in prostate cancer, but I'm rather going to try to give you a broad overview of what I think is going on in the field right now. So we're going to cover germline versus somatic testing, which I think Santosh did a great job of covering a little bit on already. We're going to talk a little bit about who we should be testing, what we're actually testing, the role of a genetic counselor, because I think this is an important aspect, and we'll finalize with a little bit about why we're doing this in terms of some of the clinical and therapeutic implications. And Vivek touched a little bit on that as well. So just to kind of set the stage a little, I'd like to talk about a couple cases just for you guys to kind of keep in mind as we go through the talk. Now, the first is a case of a 36-year-old completely healthy male who comes to see you. He has a family history on his father's side of various cancers. He believes there's a history of breast and ovarian on his father's family side and thinks his father had prostate cancer as well. He did have genetic testing done earlier, which showed that he is a carrier of a BRCA2 mutation, and his family doctor ordered a PSA, which came back at 0.8. Now, he's been referred to you to see if there's any other prostate cancer evaluation that he needs at this moment. Keep in mind, 36-year-old, otherwise healthy guy. So the next case is a 73-year-old patient, completely different end of the spectrum, presented with a PSA of 400, and a biopsy showed a Gleason 8 staging found retroperitoneal and pelvic nodes, and he had some mets in the lumbar spine as well. He was placed on ADT, which gave good control for about 3 years until he started to progress. And at that point, he was placed on Xtandi, which gave him control for about another year, but he started to progress again. Now, the medical oncologists are recommending that he go on docetaxel chemotherapy, but he is not interested in chemotherapy, and he wants to see if there are any other options that you could think of for him. So these are the two cases I just want you to kind of keep in the back of your mind as we go through this talk, and we're going to touch a little bit on, some of this as we go through. So the field of prostate, or even cancer treatment in general, is a rapidly evolving one. If you look, there are new agents that are coming to the field every single day, and the majority of these agents now tend to be targeted therapies, and they're all linked to working towards actionable mutations that are found on genetic analysis. So this field is definitely a emerging one that we're all going to have to get into and know a little bit about. And unlike the previous talk you heard with Dr. Parekh, where you're talking about specific genes that are in a specific signature and where it's being used more to tell you how bad a tumor is or what its biology is like. So you're using kind of like a risk stratification tool. Here we're talking about testing a more larger set of genes, more comprehensive testing to see if there's something that a person could be at risk of inheriting or actionable mutations that can actually specifically be targeted by therapies. And that gets into the germline versus somatic testing, or genetic versus genomic testing. So genetic testing is kind of more germline, and the real purpose of that is to look at individuals who may carry an inherited mutation that they could pass on to their children. Essentially, you're looking at a smaller group of genes when you do that, and common ways of doing it is taking a saliva sample or a blood sample. And usually you're going to be doing this in patients who are earlier on or even advanced in their care, or even healthy individuals in response to family history or something like that. Now, somatic testing or genomic testing is mainly to look for driver mutations that you can actually employ targeted therapies towards. So you're looking at a much larger sample of genes, hundreds to maybe even thousands of genes. And there you're looking at either taking DNA or RNA directly from the tumor cells itself, so biopsy samples, or you're looking at circulating tumor DNA that you could get from the plasma. And here you usually have a cancer diagnosis, and it's done mainly in advanced settings, and it can actually impact the clinical care. So we're going to talk about both of these. We're going to start mainly on germline case testing first. So I think this field really emerged after a couple of these papers came out, and they're not that long that it came out ago. And first paper was about 600 patients with metastatic prostate cancer. This was a study by Pritchard in New England Journal, and it showed that about 12% of patients with metastatic prostate cancer had inherited DNA repair defects, usually in some of the homologous recombination repair genes. So BRCA1, BRCA2, but about 12%. Another study looking at about 3,000 men with a prostate cancer history showed that it was as high as 17%. So anywhere from about 12 to 17% in metastatic patients. If you're getting into the castrate heavily treated, you're going to even see higher rates. And that compares to about a rate of 5 to 7% in localized cancers. So I think this is the reason why we are seeing more and more consensus and recommendations that these patients in metastatic disease should be offered this testing, because there's a high chance that they may have some of these germline alterations, and that can have implications in terms of family testing and as well as therapies that they could be available for. So when you look at guidelines, NCCN is a very popular one we often go to, and you can see here for any regional or metastatic patients, they are recommending genetic testing or germline testing, as well as somatic testing. Now, in terms of patients with, and that's, I think, a good consensus across all guidelines, and I'll come back to that. But some guidelines will also talk about testing in patients with localized disease. Now, usually they're going to be looking at select high-risk features, so either very high risk or high-risk tumors, so Gleason 8s or higher, T3 disease or higher. In Ashkenazi Jews, for example, some of these sequencing studies have shown very high risks of these inherited mutations in this population. And then there are some guidelines which will actually call for it in an intraductal or ductal cases because they have a high risk of these inherited mutations. Another group of features that you want to look for in patients, again, in localized setting, is mainly a strong family history. So if they have a family history of an inherited germline mutation, or if they have a first-degree relative, brother or father with prostate cancer, or 3 males in their family with prostate cancer, ideally one with an age of diagnosis less than 60, or metastatic disease or lethal, very strong family history kind of linking, then it's people that you want to consider. And then also just to consider the syndromes of cancer syndromes that are out there. If you see strong histories of 3 or more cancers in one side of the family, you have to think about things like Lynch syndrome, other things like that, and you may want to consider germline testing here. So in terms of what we're testing, the sequencing studies that were done on those 3,000 patients, these were the genes that were most often found. You can see BRCA2 was the most common. You can see the chart on the right here. BRCA1 was there as well, ATM mutations. Most of these are mutations in DNA repair genes, and ideally those homologous recombinant repair genes that Santosh mentioned earlier. So those are the ones that most testing panels will actually target. So when you look at the different guidelines that are out there, this was a review paper by Stacy Loeb that was put out this year. And you can see that on the top, the concept of germline testing in metastatic men, you can see most guidelines suggest that we should do germline testing in metastatic men. So that's something I think we should be doing. In terms of men with localized cancers with high risk features, so some of the features I mentioned before, most of the guidelines do suggest that. The NCCN does, the AUA does. The Philadelphia Prostate Cancer Conference that was just put together to look at germline testing does recommend that, but again, it's in select patients. And then most of these guidelines will say that you want to look for BRCA2, BRCA1, ATM mutations, or other of those mutations that are going to look at these homologous recombination repair genes. And again, most of the panels you're going to get will look at this. Now, they also comment on the recommendations for genetic counseling, and I'll get to this in my talk too, because I think this is key. There are a lot of implications in terms of this germline testing, in terms of inherited risk, cascade testing, things that I don't know that us as urologists necessarily are wanting to get into. So I think all of the guidelines really recommend getting in early referrals to genetic counseling for these patients so they can play a much larger role earlier on, not just if you find something. So that brings us to this point here right now. And, there is concern with, as you see next generation sequencing increasing in all advanced tumors, there's a real shortage and limitation of the availability of genetic counselors because they're playing a larger role in a lot of this. So there's been various different approaches mentioned. Some would say you send them right off to a genetic counselor pre-testing, let them do the testing and the counseling and everything that comes back. Others would suggest that we can send them off. And if it comes back negative, there's nothing needed further. But if there's anything positive, or if there's a strong family history, then they should still be sent to a genetic counselor. So, I think you have to look at, your environment and what's available and see what suits you best. But getting them involved, if possible, is definitely, I think, an important factor and recommended by almost all guidelines consistently. So we're going to leave germline testing a little bit here and now go into the role of somatic testing in metastatic prostate cancer patients. And we're going to speak a little bit about the therapeutic implications. I think Santosh mentioned some of the newer agents that are available now in metastatic castrate-resistant prostate cancer. And while a lot of this has been going on in other fields and we're just kind of catching up in prostate, this is really an area where we are seeing how next generation sequencing can provide us information that can give targeted therapies that may help patients and allow them to avoid other more toxic therapies. So this was a study that gave approval to Rucaparib. It was about 115 men that were involved. They all had BRCA confirmed mutations, BRCA1 or BRCA2, but they were really looking at this population of BRCA. And these are heavily treated patients. So they had, I think, at least 2 androgen-directed therapies and at least 1 taxane chemotherapy. So they've kind of exhausted most of the spectrum of prostate cancer available therapies in that metastatic castrate-resistant spectrum. And what they looked at was response in terms of radiological response and response in terms of PSA. So if you look here on the chart to the left, is that numbers that are going down on this y-axis are basically a decreasing size of masses in radiological response. And you can see this dotted line here represents a 30% decrease, and you can see most of the patients kind of saw that. There were some patients that obviously did progress, and progression was determined 20% or higher. And you can see there's a couple that actually did get into that across that dotted line there. But the majority showed decreased size of tumors. You can see the tumors were growing smaller. So they considered that a good response. The bottom right is showing your PSA response. So you can see the defined progression in PSA as a 20% or higher increase in the progression, the number of PSA versus response, which would be 50% or less. Again, this bottom hashed line. And you can see the majority of patients did have that kind of PSA response. Now, whether this is going to translate to, a more tangible outcome down the road will still have to be seen. But the durable response in imaging, durable response in PSA in these heavily treated patients is a pretty good early sign. So with this, Urooncology did get approval to be used in metastatic castrate-resistant patients who have a BRCA1 mutation and have failed previous androgen deprivation or androgen-directed therapies and taxane therapies. Now, the more recent study is looking at olaparib in metastatic castrate-resistant prostate cancer. And this was a randomized controlled trial. It looked at about 400 patients with metastatic CRPC who had previously had an AR-directed therapy, so either enzalutamide or abiraterone with prednisone. And they had mutations in HHR genes. So they separated it into two cohorts. They randomized them in a 2-to-1 fashion. Twice as many people got the study drug olaparib, and 2-to-1, one of them, getting the placebo. And then among them, they randomized them into put them in two separate cohorts. Cohort A were these people that had BRCA1, BRCA2, or ATM mutations. And the other mutations in homologous recombination repair was in cohort B. So when they actually look at cohort A, these BRCA1, BRCA2, or ATM mutations, you can see that overall survival was improved in the patients that got the olaparib compared to a next best enzalutamide or enzalutamide or abiraterone, whichever one they didn't get the first time around. Now, this trial did allow a lot of people to cross over, so that would affect the survival. But when they adjusted for that, you could see the survival was even better in the treatment arm. Now, when you look at the other cohort who didn't have the BRCA1, BRCA2, or ATM, just the other homologous base repair genes were defected, you didn't see that same degree of survival. So when you look at this survival, in that group of patients with BRCA1, BRCA2, ATM that got that benefit, it did get approval for an option for therapy in these patients even before getting a taxane. So that was a pretty big, move in terms of these, improving the kind of availability to these patients. Now, when you look at the side effects of this treatment, they did see a high amount of adverse events. Any adverse events was almost everybody, 96%. But when you look at grade 3 or higher, it was only about half, and the majority of those patients were those with anemia. So it was very manageable, some of the side effects, compared to, let's say, chemotherapy would have been the other option. So I guess considerations when you look at this trial and some of the data, about 28% of the patients, they didn't select out these guys that only had mutations. They looked at a large cohort and figured out how many of them had these mutations. About 30% had these mutations that were there. The overall improvement in survival was only about 5 months. So you can kind of depend on what you think the worthiness of that is. And a lot of people would argue that next best androgen-directed therapy was probably not the best standard of care. Most of these patients would have been advised to go on to taxanes. And there are other trials looking at that in that space as well. But regardless, when you look at it, NCCN guidelines and what they recommend in terms of somatic testing, they do recommend testing in metastatic disease, mainly because it could be informative to the availability of these medications if they fail initial therapy. It can be helpful in terms of genetic counseling and clinical trial eligibility. And when you do somatic testing, you may see the mutations that could be suspected to be in the germline that come up. Now, most of these testing panels will let you know if there's a germline mutation, and they tell you not to draw too much on the somatic information because you need to confirm it in the germline. So when you're doing somatic, you're looking at the tumor, and that tumor is coming from a person. So it's going to inform you about genetic traits of that person, but they need to be confirmed with germline testing before you can truly say that, hey, you do have a BRCA2 mutation that's going to be, an issue for your children. And as Santosh mentioned, there are also testing for microsatellite instability, mismatch repairs, because there is a broad kind of inclusion of patients that have these type of genes that may benefit from pembrolizumab. So I don't think we do a lot of that in prostate cancer. It's a lot, very rare that these patients are candidates or have these, but in the very advanced cancers that have exhausted all the other therapies, if you have one of these mutations, it could be an option. So they do recommend testing for that as part of the gene panel that you have. Now, as far as what you test, and that's will be the last kind of part I talk about before closing, in terms of, do you test the primary archive specimen? Do you test the metastatic, biopsy on something, or do you send blood if possible? The NCCN recommend a metastatic biopsy as much as possible. So if you have, what's the best option? It's going to be taking a biopsy from the lymph node or wherever you can, because that's going to really tell you about the tumor that's probably progressing. But again, it may not always be that easy. And so plasma ctDNA is a possibility. But again, it'll depend on your tumor burden. If you don't have a lot of tumor burden, you're not going to find much in the plasma. And they do comment that repeat testing may be required. And again, this is going to create the limitations on biopsy. So in the study that I mentioned, the Triton study, the Profound, those are the ones that got the approval for the last two agents. They used primarily archived prostate cancer samples for somatic testing, but they had about a 31% failure rate. Now, Triton did have some of those testing done through liquid biopsy, so they were looking at plasma, and the failure rate was only 4%. So, I think while the NCCN definitely does recommend histological sampling of the metastatic biopsy, plasma can definitely be an option, and this is a recent study that actually just got published this month in JAMA Oncology that looked about 51 men from 3 different cohorts. One of them was Foundation One, which is a vendor in this space. And the other 2 cohorts came from the University of Washington. And what they did is they had archived prostate biopsy samples that were about 5 years old, and they compared them to biopsies of the metastatic sites and plasma ctDNA. And what they saw was about 84% concordance. So they actually do feel like you can use these primary archive specimens in most cases. If you get a fail rate, you get a fail rate, and it didn't work, and then you may have to go to something more contemporaneous. And then when you look at it, I think liquid versus tissue is always going to be best, but not all those patients are going to want to go through that biopsy for that, especially knowing that you may have to do this after every progression. So when you look at the tissue side, yeah, you can have more confidence that a negative result is truly negative. You have higher sensitivity of what you find, but tumor heterogeneity is going to be an issue, finite resources. From a blood standpoint, it's obviously easy to get. You can do biopsies repeatedly, from sampling. The main limitation is that ctDNA is going to be dependent on the tumor burden. If you don't have much tumor burden, you're not going to be picking up free DNA from the tumor, you're picking up something else. So if you see a negative test with plasma, I think you can't just assume it's truly negative. That's when you may want to go and say, let's get the biopsy to prove it. But if you do plasma and you see something, that's a pretty good concordance that's what you're going to find in the tissue, I think. These are some of the companies that we have available right now to do some of this testing. But that was kind of it. So if we go back to the cases just to close, you had this 36-year-old gentleman who was coming to us with BRCA1 mutation. What are the implications that for him? The only guideline that would even suggest we do kind of testing of this in patients and that it has implication was the Philadelphia conference. And that may say that these patients with BRCA1 may have a higher risk of being on surveillance because they're going to reclassify. And in general, they tend to have more adverse cancers. But most guidelines would suggest for a person like this, they should probably start screening at age 40 or 10 years younger than the youngest person in their family that was diagnosed with prostate cancer. And you'd kind of follow them otherwise the same, but there isn't much that you would do differently. And for this gentleman that we mentioned before, who had kind of gone through a previous, androgen-directed therapy and not interested in chemo, you could always sequence the tumor and see if he does have any of these, DNA repair genes, and it could be a candidate for PARP therapy. So that's, so in conclusion, germline testing and somatic testing is recommended in men with metastatic prostate cancer, hands down, by almost all guideline committees. So that's an easy one. If they have metastasis, send them to a genetic counselor and considering sending the prostate for next generation sequencing. You can consider it in select men with localized disease for high risk features or family history, but it's not often done that much. I think I mentioned a genetic counselor is very important. They play a strong role in that. And the landscape of available therapies is rapidly evolving. So while we may only have a couple that we're looking at now, I think this is going to grow in the next 5 to 10 years. So thank you very much, and happy to take any questions you have.
Thank you so much, Dr. Punan. So I'll just give you just a brief idea about these kind of tests in India. I feel quite awkward following two such great talks. But just to, kind of complete the circle, and then we can have a little discussion after that. So first off, the molecular biomarkers. So in the biopsy space, there are none which are still available in India. So I'm really happy that Dr. Parekh spoke predominantly on the Prolaris Oncotype and the Decipher, because those Prolaris and Oncotype are available in India, but as you can see, they almost cost as much as a robotic prostatectomy. So whether or not these need to be done or in whom they should be done, I think we had a very, very good discussion through Dr. Parekh's talk. So in active surveillance, as of now, only Prolaris has been validated on the biopsy sample. Anyone who treats prostate cancer in India knows that of the people you see, there's a very, very small minority who are actually eligible for active surveillance. There remains a very high risk of upgradation on subsequent biopsies or on the radical prostatectomy specimen we do see, because the pathology is still not that well centralized and not that well reported. And I think India is notorious for a poor compliance in terms of patient follow-up. So it's really a minority of patients who you actually recommend to come back in 6 months or a year that would actually come back for that repeat biopsy. Often they think it's all okay, doctor says it's fine, let's just forget about it. So, there's a lot of very, very limited role probably in the space of active surveillance for any of these biomarkers. When it comes to adjuvant treatment after radical prostatectomy, is there any real difference between adjuvant and salvage? We've got radicals data right now, so whether this really makes any difference to additionally do one of these genetic tests, probably we need to wait for some good evidence. And as Dr. Parekh showed us all the limitations of these tests, there is one more, and I think a question was asked about it, is are they valid in an Asian or an Indian population? So that as of now, we really have no data regarding any of that. So maybe something to think about before we, order it helter-skelter. So these tests, they may prognosticate, but whether they change clinical outcomes also remains to be seen. So as of now, I would say probably the only time we would order it is if a patient really demands. Maybe someone who has family in the US who has heard of these tests. These are probably the only situations that we may, ask for one of them. Moving on to genetic panels, they are increasingly available, increasingly accessible. There's a lot of promotion from companies, especially after the introduction of olaparib and rucaparib. There are a number of panels, and we have a number of Indian as well as foreign companies that do provide germline and somatic testing. So the cost is not that bad. The Indian cost for prostate-specific panel is about 20 to 25,000. And with the company, they give a discount. It comes to around 17,000. And the foundation one costs up to 1.5 lakhs. So as Santosh and Dr. Poonen showed, these are the common genes that we do test for. The HOXB is the one where you're suspecting some kind of familial prostate cancer. And that's more like a theoretical basis to find out if that patient has one of those mutations. So when we are moving on to the indications for germline testing to personalize cancer screening, what we need to understand is that this is a very personal decision. If a young man wants to, find out his risk of prostate cancer in the future, if there is a strong family history of multiple cancers, that's when you may consider doing some of these panel tests. But what we don't realize is that there could be a very big potential impact in terms of the patient's family and subsequent cascade testing that might be needed for them, employment and access to health insurance. So in the US and other countries, there is a protection that you can't discriminate against these people, even if they have a germline mutation in terms of employment and access to health insurance. But I don't think any such law exists in India. So it's maybe something to think about. That's why genetic counseling in this particular situation is really, really crucial. So as of now, in a country where even PSA testing is really not routine, to think about germline testing to assess a personalized risk of prostate cancer seems a little far-fetched. But who knows if it really works? Maybe in the future, instead of checking horoscopes before marriage, we may check BRCA mutation or something like that. Next indication is the newly diagnosed high-risk localized disease, which is recommended in NCCN. And I think even NCCN recognizes that the impact on management in this situation is not really that significant. It's more a prognostic test. So probably, I think in this situation, the role in India would probably really be minimal as of now. The next is the metastatic setting, and I think this is where we really need to focus our attention. Dr. Punan's talk really covered this well. So there is a potential for therapeutic targets and enrollment in clinical trials. And ideally, it should be done routinely in those who have metastatic disease. But I think it's something that is worth discussing with each patient that we see and letting them know that this kind of testing is available. It may help in the future in terms of potential targets for your cancer, and give them a referral to the genetic counselor. I know even in India, they are not so commonly found, but if you have access to a good genetic counselor, this would be an ideal situation for a referral. Somatic testing, I think as of now is a no-brainer. We need to do it before assessing for treatments like PARP inhibitors, immunotherapy, and even platinum-based chemotherapy in some cases. So this is where the sample from the prostate is taken and prostate or the metastasis, preferably metastasis, to look for any actionable mutations and tailor the treatment to that mutation. So I think in conclusion, there is a potentially big role in the future, but we are nowhere near prime time as yet. And especially for molecular biomarkers, there's a long way to go for routine use. Germline testing, I think we should consider in metastatic disease as discussing with the patient and referring to a genetic counselor. And somatic testing definitely has an indication when planning subsequent therapies in the metastatic setting. So thank you all, and thank you to my teachers for all their guidance throughout my career. So I hand over now to Santosh. I think as of now, there are just a couple of questions. I thought I'll ask Dr. Parekh about in the pre-biopsy setting in terms of the 4K and the PHI and things like that, because we don't really have any of those tests in India. How commonly do you use them, and do they, play a real role in the management of localized disease? In the management of patients with an elevated PSA.
Yes, so Vivek, as you know, we do use the 4K score quite commonly. We are one of the leading sites that tested the 4K scores in clinical trials to begin with. The reason we like 4K score is because it actually gives you an individualized risk of aggressive prostate cancer. To me, that's most important. I'm not interested in yes or no answer for prostate cancer. What I'm really interested is in the yes or no answer for aggressive prostate cancer that I don't want to miss. So typically, unless it's a very clear-cut thing that you got to just do a biopsy and you're doing an MRI just to locate the biopsy better or target the biopsy better, in that situation, I forego the 4K score. But otherwise, for a routine men with elevated PSA, my pathway is to do a 4K score and MRI both, and use that information in combination to determine the biopsy and whether or not to do the biopsy. And then I think Sano just showed very well too that actually you can, the 4K score cutoff, there are several cutoffs at 4K score. I think it's a 7 or 7.5, beyond which, even the MRI could be eliminated if you want to. So and he has done a great job in terms of teasing out the value of 4K score and MRI in combination. I mean, obviously we don't have a large sample size, but it's enough to give us some guidance. But my pathway in a de novo patient, unless it's strongly suggested that you have to do a biopsy anyways, I do a MRI and a 4K score. Sanoj, what do you do?
Yeah, something very similar. I tend to do the MRI first, just because access to an MRI is not that difficult for us. If it's positive, I know that the information is there and we're going to go. And then if it's PIRADS 3, let's say, or negative, that's when I'll often get a biomarker, because I worry that if the MRI comes back negative, then we still miss about 20% of cancers when the MRI is negative. And that's where I find the biomarker to be very helpful. But that's in the setting, we're in an academic institution where we have radiologists and all the, in terms of, I think, several different scanners that are all PIRAD certified. In different settings, you may want to start with the biomarker, because as Dr. Parekh mentioned, if that comes back low, you can eliminate any other further need. So, and there's a lot of variability with MRI. I read my own MRIs that Dr. Parekh does, and we know we can trust our radiologist as well. But if you don't have that kind of trust relationship between, or you're not comfortable, there can be a lot of variability, and MRI can introduce a lot of issues. And so in certain populations, I think a biomarker is a good way to go with in the beginning.
We have some comments that the PHI is available. I did search for it. I heard about it, but I couldn't find it on any lab website. From what I understand, it's not validated for high-grade cancer. It's validated basically for any cancer.
Any cancer.
So which is where probably the 4K scores over that in that situation. And Dr. Ponen, if the somatic tissue shows a mutation which can be targeted in terms of treatment, do we need a germline test to confirm that, or we can go ahead with the treatment as such?
So I think you can go ahead with when you're thinking about the somatic mutation and things like that, you're talking about that one particular person and what their tumor is going to do. So, in that sense, I think, yes, you can go and say that they may be a candidate for this. Where the germline testing comes important is more a matter of, is this in their DNA that they could pass on and their children could have it? So I think when you see most, for example, Foundation One, you guys mentioned that you have that there too, they will give you a list of suspected germline variants that came up in their somatic testing. And it is recommended that you then get a referral to a genetic counselor to do the proper germline testing, because it may have implications for them from a family standpoint. But from them and what their tumor is doing, we already know.
Santosh, anything else? Any other questions?
No, nothing much. I just wanted to ask Dr. Ponen is that he, as a continuation of the question raised by Vivek, is that if on somatic mutation we find some very strong evidence of genes, then would it be right to go back and find out whether it's something which has happened from birth, germline, and then then the patient can be counseled or something? Is this something which you advocate, or?
Yeah. So, I mean, let's say, for example, you sent an old prostate cancer biopsies on a patient now who's gone down the spectrum, and there are some BRCA1 mutations that are found, BRCA2 mutations found in somatic testing. It is probably worth getting germline testing in that patient if they've never done it, Now, I would probably do that by referring them to a genetic counselor. They'll do a mouth swab, because it doesn't. So the concern is you don't want to draw too much conclusions about a person's germline just from their somatic testing, because the more treated a tumor is, the more mutations that are going to happen. So when you look at people downstream, their tumors get all these inherited mutations through all the treatment cascades and everything else. And so what you may find going on in the tumor may not be in their germline. So often, but you need to confirm it, because if it is in their germline, then it has inheritance implications.
There was a question for Dr. Parekh from Lucknow. So the gentleman is asking whether the tests are just not good enough in terms of prediction, or is it just that we don't have the prospective data? What is your gut feeling about that in terms of how well they are used in breast cancer as opposed to prostate cancer? So you're mute, sir.
I think they're just not good enough on their own in terms of prostate cancer. Prostate cancer is a much more heterogeneous disease, I think, compared to many other cancers, and they're just not good enough.
Okay. And Dr. Kashyapi from Pune is asking, do you think urologists can be trained in terms of the genetic counseling that is needed in terms of counseling patients for all these germline tests? What do you think, Dr. Pune? I think more experience ordering, probably we may be able to counsel a bit better, but.
Well, sure. Yeah. I mean, I think this is where I'm going to answer a question with a question. Do urologists want to be trained on all the things that need to happen with genetic counseling? Because there's a lot that goes into that in terms of knowing all the syndromes and everything else, and basically knowing what kind of family histories we should be looking for, then the implications of all of this. So I think if there's a certain person, a urologist that wants to have a niche in that area, yeah, absolutely. And could we take on a little bit of this genetic counseling in terms of knowing who should be sent off for things and what we do with the results if they're negative completely and there's not a strong family history? Sure. But I think if there's any question, it's best to send them to a genetic, because there is a lot in that, and it's not something that we just quickly learn.
Okay. Great.
So the genetic counseling, Dr. Punan, is it the whole process, the counseling when it is done session, it's only the genetic counselor who is there, or the treating physician is also there during that to answer some clinical questions, or it is just the genetic counselor with the patient and the relatives, or how is it usually done?
Yeah, I mean, for us, it's a separate visit with a genetic counselor provider. So we're often not there. I don't think there's anything that prevents a person from being there, but I mean, you could get the information and the information back. I think usually what I've seen is we refer them, they'll have a discussion, the testing goes off, and then there'll be a note that I get back about, was there any implications from the testing? But yeah, the real thing you want is the information. And it's nice to have them to guide the patient, which can be a little bit outside our wheelhouse.
Yeah. So ideally, at the end of any algorithm, I usually summarize and try to get things sorted out so everybody knows what they have to take home, and that's sort of a take-home message. But I've been making my own notes as I've been listening to everyone, and a lot of things I've learned, and I've tried to make things a little bit more easier and put some algorithms. They will be definitely reflecting on what has been discussed, and I hope that the viewers are able to take some good messages along with them at the end of this webinar, that will help them to treat their patients in a better way. As rightly said, molecular markers, there is no consensus as such. But if you are going to consider Prolaris or Oncotype in patients for example, say active surveillance, you have to talk about test limitation. That has to be taken into consideration, and not to forget the variability and heterogeneity which the prostate cancer presents with. Of course, cost is a big issue, and when Dr. Vivek mentioned about it being equivalent to a robotic prostatectomy, it really hit me. And applicability is an issue. So I would say that we are still awaiting good evidence, and if it is available, and then we should incorporate in our treatment algorithms. Is genetic analysis important? It is. I mean, if you have heard the talk, you can see that it covers everything from screening to treating localized prostate cancer and advanced prostate cancer as well, especially the metastatic CRPC patients. When to do it? Before that, I just want to put a disclaimer, as Dr. Parekh mentioned, that prostate cancer itself is associated with a lot of heterogeneity. Things keep changing every time and then. But the NCCN guidelines acknowledges the consideration of HRR and the MSI, the MMR genes in patients with especially regional and metastatic prostate cancer. So they have this recommendation coming up. So with germline is used in this favorable intermediate and very low and low, especially if the patient has got a family history which is positive and intraductal histology. We've talked about very high risk, then it is definitely recommended. So is it recommended regional metastatic. As far as using the other genetic test is concerned, it can be focused on the metastatic prostate cancer. Germline testing has been very widely covered in the talks, and I'm not going to add anything more, but I'm just going to emphasize that patients with high risk and very high risk regional metastatic prostate cancer, or those who have got a family history of germline mutation as well, Lynch mutation and positive family history, which looks at more than 3 cancers on the same side of family, whether it can be bile duct or colorectal or kidney or pancreatic or breast cancer. These are the patients and young patients who have died from prostate cancer, or who have father or brother, multiple family members who have been diagnosed. They are someone who are suited for germline testing. Now, which to do? If you look at this pie chart, you'll find that the somatic mutation tend to give a little more evidence as far as genes are concerned. But I guess this all depends on the patient in front of you and how you decide to go about, what sort of test you're going to plan for that patient. Now, which panel? It's been discussed. I won't be going much in detail. These are the genes which have been put up here. HOXB3 is a very, very important gene. So is BRCA2. and the ATM, and we have the focus panel for 5 to 6 genes, cancer-specific panels for 10 to 15 genes, and the comprehensive panel for 80 genes. And these are the major genes which cover the metastatic prostate cancer, non-metastatic prostate cancer, and the men with no prostate cancer, when they need to know whether they have cancer or not. These are the genes which almost overlap in all these scenarios. And these are something which I'm putting up because you need to know them, because whenever a panel is brought in front of you with many of the companies, you should be knowing what that panel contains, what sort of gene that panel contains, and not blindly prescribe a panel for a patient if you are planning to do a genetic testing. When to do it in metastatic stage, this I'm putting up because it's a question which is very commonly asked. I would probably believe that if it is done early at the time of diagnosis, we would probably get more information. Why I'm saying this? Because if you look at this example for biallelic BRCA inactivation, then the increased response for platinum-based chemotherapy. If you are looking at germline BRCA2 genes which are picked up, then this patient may have an increased effectiveness of abiraterone and enzalutamide. So these are the information which we can have beforehand when we plan the treatment sequence in these patients. Fresh or archived sample has been described in details. There's not much difference, but archived samples are acceptable. But if it fails, and if you can plan a second biopsy, but of course you have to go through the tumor board for that. As far as primary and metastatic site biopsy is concerned, there is a little bit of tendency of the metastatic site being more productive as far as giving information is concerned, but it's almost tend to be the same. In Indian scenarios, as far as genetic tests are concerned, as Vivek rightly mentioned, to screen somebody, to tell somebody beforehand that you may have cancer is a big impact on the family. We need to have good counselors, and as physicians ourselves, we need to upgrade our knowledge and understand more about genetic testing. Of course, in high-risk cancer prostate and metastatic cancer prostate, prognostication is needed, and that's where genetic tests help. So is in cases where the patient has got a strong family history. But again, I keep saying this, that the cost is the most important part. And as the pharmaceutical companies have rallied and tried to get some patient-friendly schemes, I hope the genetic labs do the same in future to help the patients get advantage of it. And of course, if the patient demands, then you have to really decide on to what test. I'm hopeful that after this webinar, the viewers will be able to decide what tests they can order for the patient. Looking at the molecular biomarkers, again, the availability is important. Just now, there's a comment on the comment screen is that even Nadiad has got the PHI available. So there are centers which we can earmark, and if they want to do it, they can do it. And whether it can help us to understand active surveillance, where active surveillance itself is not that active in India. Not many people practice it, but there are few cohort of patients who would love to be on surveillance, but that entails a lot of other logistic issues, including the risk of upgradation. Cost again, and the patient demand again is an issue. And most important is whether these are validated to Indian scenarios, Indian demography, and of course, what are the clinical outcomes in terms of our demography is something which we need to understand. I'm putting this slide up importantly because this is a study done by Vedagiri, and she has put up this big flow chart, which I'm putting up. Of course, you won't be able to read it, but you can always go and read it up and get an understanding of how she has outlined the sort of an algorithm here of how we can use genetic tests, especially germline testing, in ordering the right test for the patient at the right time. With this, I end my talk algorithm. I hope this was an informative.